Our next speaker is Matt Longjohn from the YMCA on the diabetes prevention program. Matt.
I'm actually speaking both about the LiveStrong with YMCA and the diabetes prevention program. But at the risk of irritating workshop planners, I'd invite everybody just to stand for a minute. It's been a long day already. Got to be about physical activity all day long. Bill and I go to a lot of meetings where after everybody speaks, there's actually a standing ovation no matter what somebody says, just as a principle of promoting physical activity. Thanks. And feel free to get up, walk around, etc. as I go through this as well. I don't have that many slides. It's a pleasure to be able to talk a little bit about the WISE experience here, and I think you'll find that we're trying to find that middle ground between evidence-based practice and practice-based evidence, figure out how to scale things. If the Y is expert at anything, it's at scale. It's at figuring out how to bring things that have maybe been shown to be effective in one place to thousands of other places. Maybe that's something that'll be useful. Today, I'll talk a little bit about a program named LiveStrong at the YMCA, and also, in particular, go over what the program is, its history, the evidence behind it, and the current status of that program nationally. And then also borrow from the history that we have in scaling the YMCA's diabetes prevention program and other programs to give you maybe a few other ideas to think about in terms of strategies for sustainability, an advocacy agenda, variety of things like that, because we believe that what's coming is an era of community integrated health where the value that's possible for community-based organizations to provide to a transforming healthcare system is going to be an imperative for people to realize and leverage. So the LiveStrong at the YMCA program, first of all, I should say a little bit about the Y structure in case you haven't gone to a while in a while. There are 22 million active members of the Y nationally, about 8% of the population at any given time, but many more than that when you consider people who have had an experience with the Y over their lifetime. There is one YMCA kind of structure nationally, and YMCA of the USA is the National Resource Center to help that entire national footprint. That's where my team is located. But there are actually a federation of almost 900 nonprofit organizations that make up the YMCA. They manage a total of about 2,700 facilities. Those are the places where you drop your kid off to swim, or maybe you go to swim yourself or work out, or maybe a campground, things like that. And because so many of the programs that we offer are offered in schools, for example, we're the largest provider of Head Start in the country, or in clinical settings, et cetera. There's actually over 10,000 program sites that we manage, and we've been scaling things through that system over the course of about 165 years. Jennifer showed a slide earlier today that showed that it's actually just over 75% of U.S. households are within 5 miles of one of our 2,700 facilities. And so when you think about where the opportunity is to partner with a community-based organization and partner with public health and healthcare, we think that we have a lot to offer. And last point is that we will never meet at the Y the demand that exists all over the country for any number of conditions. So we're committed to, with partners like the Robert Wood Johnson Foundation, et cetera, teaching other community-based organizations what we are learning so that they can, in fact, leverage some of these lessons as well and maybe partner with you in your community. So this program is a program that is also inclusive of organizational change. We'll talk about what happens for a survivor in the program context, what happens when they're with their instructor. But what's maybe most novel about this particular program is to begin delivering the program, a Y has to license it from YMCA of the USA, and they have to be, they go through, bless you, about a 6-month organizational change process, actually. We train front desk staff on a variety of things, kind of how to maybe recognize and be more empathic towards a survivorship community. Facilities are maybe maintained sometimes differently if you've trained your staff to think about what an immunocompromised person might look for. That front desk staff, we've got lots of great videos of front desk staff being trained to recognize that if someone comes in that kind of quintessential bandana and looks a little uncertain, how to provide a little bit more open-ended questioning and guide someone through their membership onboarding process in a different way. We have to give grief counseling training to our staff with this program, and haven't had to do that before. Motivational interviewing, group facilitation. It takes about 6 months for a Y to become a Livestrong at the YMCA program provider. During that time, they've assessed where the cancer centers are in their community, or where the healthcare system might be feeding cancer survivors to them from. And then, when they are delivering the program, they have a better understanding of what they're actually achieving. So this has been a proud partnership between the YMCA and the Livestrong Foundation for nearly 10 years. While I'm still meeting certain of you, including Dr. Irwin, who I just met a couple minutes ago, I know that there's actually been a variety of you all who were involved in advising the Y and the Livestrong Foundation going back 10 years on the creation of this, and thank you for that. But to date, we've served almost 41,000 people, and these are actually old numbers. We don't have this hooked up to be a click of the button kind of thing to push out numbers, so those numbers are about 6 months old. We expect that we were probably closer to about 44, 45,000, something like that at the end of last year. We'll know in the next couple weeks. We have 211 of our corporate YMCAs that have been trained to deliver the program in about 550 program sites. Unlike other programs that we deliver, like the diabetes prevention program in many community settings, this one is really anchored inside the YMCA because of the fitness facilities and things like that that are utilized. This is spread across 39 states, and there are about 3,000 certified instructors. I have a font problem here. What does it say? Program basics. So this is a program for adult cancer survivors of all etiologies. The majority are breast cancer survivors, but it's not an eligibility criterion. It's offered in small groups, but it's individually tailored, the individuals going through this end up getting cardiovascular conditioning, strength training, balance and flexibility exercises, and this is happening in a group. It's not a support group, but there's a whole community aspect of this. Like the YMCA's history over 165 years, the Y, for example, created English as a second language courses when we founded over 100 universities 100 years ago. The DPP and other programs are often delivered with small groups. That's our core competency, going back to 165 years ago when agrarian white Protestant men came to do Bible study in urban centers. What we're good at is creating group dynamics. And that holds in this program as well, where community is formed. Incredibly compelling stories. When we lose a survivor, often the group that has been meeting, maybe they're pallbearers. We have lots of different ways that these participants support each other. It's a 12-week intervention delivered twice a week for 90 minutes, and it's held at YMCAs. We assess a variety of things, but pre and post functional quality of life assessments are routine. The data that I believe was shared just earlier this morning is just in the bottom left, showing the quality of life and fatigue scales outcomes from a paper published recently in Cancer by Dr. Irwin and others. The other metrics, I can't tell if you can squint and see these or not, that are important are the just overall improvement in physical activity, as measured not just in self-reported physical activity minutes, but also conditioning through the 6-minute walk test, et cetera. Can say more about the program, have another chance to talk about our work tomorrow as well. But I think one of the things that folks wanted me to talk about was how to take a program like this and think about it from a scaling and sustainability perspective. And over the last 9 years, with only one exception, the YMCA, the Livestrong at the YMCA program has been offered free of charge to all of those 40-something thousand participants. And Ys have, all the Ys that have delivered the program started with like a $3,000, $4,000 grant from the Livestrong Foundation to go through that training process, and that was it. And then they've been responsible for raising money on their own in their own communities. And the challenge of fundraising and sustainability has resulted in wait lists all over the country. This is really frustrating for everybody, participants as well as Y folks. And so the challenge of sustainability is one that is really one that we take to heart, one that we think about a lot. We were lucky enough in the last year to get the first federal support for scaling this program, thanks in part to advocates pushing for survivorship to be a part of the CDC's portfolio. When we talk about sustainability, there's probably no better model right now in the YMCA context than the YMCA's diabetes prevention program. The YMCA's diabetes prevention program is a direct translation. In fact, we licensed the curriculum from the University of Pittsburgh, who was the academic institution that put the little Circle C copyright on it during the NIH DPP trial. We have to license things or be paying attention to intellectual property, whatever we scale, because we've often had good programs, evidence-based programs, go to some kind of scale, 200-300 sites at a time, and then someone say to us, well, to continue this program, you have to pay this $4 million invoice. We try and get those kinds of things out of the way early, but other aspects of business development and scaling are important to take note here of as well. And the way we think about this is kind of a long-term story of translating and scaling this program. So the NIH did their trial. You saw the results a couple times this morning. In the DEPLOY study, published in the American Journal of Preventive Medicine 2008, researchers at the Indiana University School of Medicine took the exact same curriculum that was delivered in the DPP trial and took it to the Indianapolis Y and said, I wonder if you guys could deliver this. And the researchers trained the staff, they recruited participants, they did everything that happens in a trial, in a study. The question was, would it work as well in a Y? And the answer was yes. In fact, it averaged about a 6% weight loss in that particular setting. But the most important finding was that the program was delivered at 10% of the cost when compared to what was occurring in the clinical trial. So this started getting some folks' attention. In Chapter 3 of our story, the CDC came in and said to the Y, okay, well, that was an interesting study. But could you do it again, and this time without the use of a safety net? Do it on your own. Create your own marketing, create your own training system. The YMCA is a massive training system. We train about 80,000 people a year on everything from hand washing and child care to HIPAA compliance to the grief counseling I mentioned to financial management for our CEOs, various things like that. And we had to build the DPP into our training system, motivational interviewing, variety of things. So when we did that, we did it in Louisville, and we showed that we could still recruit participants, still have the same outcomes. And that's when the commercial sector of insurers started showing up. They said, okay, you've got an evidence-based program that's 10% of the cost is when it's delivered in the clinical milieu. You've got great outcomes, and you've built this into your training system. So how could we help you scale it? And a third-party administrator housed at Optum was created to manage contracts with insurers. And the Y was so confident in the outcomes of this program that we went at risk for the first, for any reimbursement. So only when people attend certain sessions or lose the weight that's correlated with reductions in diabetes prevalence is the Y reimbursed. Over 30 commercial insurers ended up working with Optum to reimburse the Y in this way over the Chapter 4 of our story. But because our third-party administrator was at Optum, competing insurers with blue logos instead of gray logos or this or that, just wouldn't sign contracts and wouldn't work with the Y. We're totally payer agnostic. So we had to find a way out of that arrangement with UHG, but we had a 5-6 year contract, and we had to learn as much as we could about what risks were involved in managing those contracts and how to stand them up. So one of the first things that had to happen was we had to go out and write our own CPT code because the CPT codes describing the professional delivery service or the service providers didn't recognize that they were non-licensed staff often. And the CPT codes often also describe the duration or the actual service in a way that was not exactly precise. So for us to enter into that kind of arrangement at YUSA and contract on behalf of our local Ys, we felt like we really had to minimize the risk of claims fraud and abuse, things like that. And we went out and wrote the very first CPT code for non-licensed staff to deliver a preventive service and got it approved about 2 years ago. And that really accelerated our move away from United Health Group. So other things to just highlights that happened here, I'll talk about in a slide or two, but we believe that after we've scaled this now to over 250 cities, this is what I was thinking of, 1,700 locations, served 51,000 participants and achieved weight loss outcomes at scale by delivering the program when we hire from the community in Somali, Hmong, Korean, Portuguese, American Sign, English, Mandarin. We've recorded it for people with visual impairments. We've done all these different things to try and bring this program to scale and address health inequities. We believe at this point that we're on the path to sustainability by proving the value that community-based organizations can provide to participants and to transforming healthcare systems. What's happening here is that Secretary Burwell, almost a year ago, on the 6th anniversary of the signing of the Affordable Care Act, came to the Anthony Bowen YMCA here in Washington, D.C. The Anthony Bowen YMCA in Washington, D.C. was the first all-African-American YMCA. It was founded in 1853. Had an all-African-American board of directors in 1853 and became the basis for over 100 organizations that were, kind of all African-American YMCAs until everything was mainstreamed almost 100 years ago. But when she came to the Anthony Bowen YMCA, she came to certify cost savings of this intervention. We had a demonstration project that went on for almost 4 years with the CMMI, Centers for Medicare and Medicaid Innovation. I don't see Darshak right now, but we served almost 8,000 Medicare fee-for-service and Medicare Advantage participants during that 3.5-year demonstration project in 17 cities in 8 states. And their entire claims histories were evaluated for cost savings. So if someone did or didn't end up with diabetes through that 4 years, obviously their healthcare expenditures were captured in that evaluation. But if they stubbed their toe and went to the emergency room, that was also captured in the cost savings evaluation. And it ended up that lots of different things contributed to the cost savings that were certified. Decreased medication usage for hypertension and dyslipidemias, 8 fewer days in the hospital per 1,000 over the course of this intervention. Over a 15-month period of time, when you standardize when someone entered the intervention and followed them for a number of years, the first 15 months produced a 5-to-1 return on investment for Medicare. For a $500 investment in a community-based preventive service, Medicare could track and certified for the first time in history cost savings from a community-based preventive service to the tune of 5-to-1. So pretty exciting, and that led Medicare to draft rules, and Medicare coverage will go into place on 1/1/18 nationwide for all programs that have been recognized by the CDC to meet the quality and fidelity requirements that the CDC created for any diabetes prevention program provider. Over 1,000 organizations are a part of the CDC's recognition platform. The YMCA is not the only one. We didn't do this just for the Y. We proved the cost savings so that all community-based organizations that commit to certain quality and fidelity benchmarks, training requirements, et cetera, can be a part of this benefit under Medicare in 2018. We have a slew of evidence-based programs that are in development, and they're at different stages of development. Falls prevention, arthritis self-management, pediatric and family weight management, programs for people with Parkinson's, et cetera, all in different stages of development. And the way that we think about sustainability here is in this term of community integrated health. We're being somewhat provocative here. For some of you in really progressive healthcare systems, you may just say, well, this is population health. And it might be in your system. But when we work at a national scale, we know that population health means something very specific to anyone who uses it, and it means something different to each person who's using it. I shouldn't say anymore, many population health departments are actually managed by the chief marketing officer in a healthcare institution. So the value of a billboard the value of an advertisement is kind of monetized and thought of as population health in some systems. That's not what we mean. We're talking about building the capacity of community-based organizations like WISE to partner with healthcare systems and institutions. We have to train WISE on the lexicon, the language of healthcare. A good example of this is we train WISE to recognize that going and asking a resident physician of whether you can work with them is less effective than going to the clinic manager and asking if you can work with them. Right? So we build the capacity of local WISE to do this work. We focus first on health equity. I mentioned some of the translations that we're doing, but in our blood pressure self-monitoring program, for example, in the first 65 cities that we've delivered the program, the average participation rate of African Americans is 36%, whereas in the population, the prevalence of African American households is about 22%. So we're overserving the population that is more likely to die, 14 times more likely to die from heart attack or stroke than a Caucasian population. We do this by hiring from the community, et cetera. So it's a health equity intervention, not just a chronic disease intervention. We understand that the basis of this kind of work is always rooted in collaboration. We've been so blessed to work with the CDC for over a decade on things like REACH and communities putting prevention to work, and community transformation grants, Steps to a Healthier U.S., et cetera, to build the capacity of our WISE to collaborate, training them on collective impact processes, being backbone organizations in 253 communities. And we've actually documented over 39,000 community change strategies that have been placed by WISE and their partners in those cities, so sidewalks, farmers markets, stuff like that. Coming around the wheel here, we recognize that we're training new staff. We're hiring new staff. For many years, I was the first and only physician in the YMCA's history at the national level. And now there's another physician in the movement. We just hired a senior vice president in our Kansas City YMCA who was actually a chief information officer at Cerner and left to come to the Y. We're hiring community nurses, community health workers, doing home health visits, checking on pantries of food insecure individuals. My point is the world is changing, okay? The community-based organizations are changing maybe more rapidly than you can research it. But with the pressure on healthcare transformation, WISE are responding, leasing space, for example, in shared spaces to healthcare providers. In Des Moines, there's a healthy living center. There's a joint venture, that's the right word, between the healthcare system and the Y. They created a shared facility. So the oncologist literally sends somebody through tubes and under tunnels, because it's Iowa, to the Y, and has referred over 400 participants to our LiveStrong at the YMCA program. Compliance is the last circle I'll talk about here, and we take this really seriously now that we have WISE with national provider IDs, and we're using CPT codes. And we just in June of last year hired Athena Health to be our electronic medical record. So all of those programs I showed, all of the data will be immediately connected to primary care providers as long as the participant consents for us to do so. Range of motion data from our arthritis program, quality of life scores from LiveStrong at the YMCA. These are the kinds of steps that we're taking to meet you all in academic centers in the middle. And what I would say is that the lesson learned here is that there's that whole process of developing things. It takes a while, but it's worth it, I think. When we are working now with oncologists, we're talking about the oncology bundled care model, the alternative payment model. How can WISE help oncologists in a kind of capitated system achieve outcomes that they're responsible for over long episodes of care? And the last thing I'll say, because I know I'm over, is that we think that as the programs that I've mentioned become more and more connected to alternative payment models, that insurers will follow what we've seen with the DPP and help us sustain this effort over the long term. Thank you.